A very good day to you. I am Jack Tay from Singapore. Welcome to the third installment of Tumor Boards in Focal Therapy, organized by the Focal Therapy Society. Focal therapy is a highly personalized intervention with the aim of treating the aggressive cancer while sparing as much of the normal non-malignant tissue as possible in order to minimize side effects and maintain quality of life. The cornerstone of success depends on identifying suitable patients for treatment, as well as close surveillance in order to treat any new lesions or recurrences early should they recur. Tumor Boards in Focal Therapy is a quarterly webinar by the Focal Therapy Society. Please do sign up and join us if you have not already done so. And I'm very happy to be joined today by our esteemed panel comprising Dr. Jeremy Grummet, Associate Professor at the Monash University, Dr. Laurence Klotz, Professor of Surgery at the University of Toronto, and also the Sunnybrook Chair of Prostate Cancer Research, Dr. Clement Orczyk, Associate Professor of Urology and Consultant Urological Surgeon at University College London, and Dr. Rastinehad, Associate Professor of Radiology and Urology and Director of Focal Therapy and Interventional Urology at Mount Sinai. Today, we have an exciting lineup of 4 cases, each followed by our panel discussion. For the audience, please input your comments or questions into the chat, and if time permits, I will direct these to our panel. Without further ado, I will hand the control over to our first presenter, Dr. Jeremy Grummet. Jeremy, please.
Great. Thank you so much, Jack, for the invitation, and thank you to the Focal Therapy Society. It's a fantastic opportunity to present on our experience in one aspect of focal, and I'm delighted to be sharing the panel with our other experts today, and I'm really looking forward to hearing their experience as well. So our experience is in focal low dose rate brachytherapy, and as Jack mentioned, we're going to be talking about patient selection today. So before I get onto the case, just a really quick summary of why we have chosen focal brachytherapy as our energy source, because obviously we're going to hear about other energy sources today. Well, the answer is that, as you all know, it's already a standard of care for whole gland treatment of intermediate risk prostate cancer. Now, that's obviously a good thing. The downside is that it's not novel and it's not sexy, so it may be harder to enthuse people in that respect. But at least, I guess, the positive is it's not an experimental modality as such. It's an experimental way of using the modality. In Melbourne, here in Australia, and my radiation oncology colleagues have been early adopters of whole gland brachytherapy a long time ago. So we've really got decades of experience and expertise. So that's a pragmatic reason, I guess, for choosing it. And finally, also pragmatic is the fact that brachytherapy is reimbursed by both our Medicare or government system as well as the private health fund. So there's a significant reduction in potential financial toxicity that's sometimes associated with other modalities, particularly in the Australian context. So as you all know, as the guidelines tell us, it's really important if you're going to do focal therapy to do it as either part of a study or at least a prospective registry. And that's what we've chosen to do. We created a registry a few years ago now called Liberate, and you can Google that to find out more details. But really important, and this comes down to patient selection, is this eligibility criteria for these cases. So PSA less than 15, clinical stage T1C or 2A. Obviously, all patients have had an MRI. This is an MRI-based type of treatment, and they need to be positive for pyrotes 3 to 5. Our biopsies are very thorough. They're all transperineal. We do targeted cores plus a minimum of 18 template cores, obviously needing to match where the lesion is on the MRI. And in terms of grade of cancer, we do include patients with larger volume grade group 1, although in the eligibility criteria, as it happens, we haven't actually had any of those patients yet. We're really focusing on the Gleason 7s, in other words, the grade group 2s of any length, core, or smaller grade group 3s, so the Gleason 4+3s. So going on to the case then, this is pretty typical, really, of what we're doing. 64-year-old guy, elevated PSA of 6.7, no urinary symptoms, no erectile dysfunction, and a clinically palpable lesion on the right-hand side. So he went on as per standard practice to get a multiparametric prostate MRI. And hopefully you can see here, the right posterior peripheral zone. This is about midway along the prostate, this hypo-intense area, particularly visible on the ADC map in the middle there. And so this patient underwent a targeted and template biopsy. And this is what the biopsy report looks like. So you can see on the right-hand side, mid, posterior, and target, you can see those grade group 2 prostate cancers with only a very small percentage of Gleason pattern 4. So, you know, you might be thinking perhaps even about active surveillance, but with such a tiny amount of Gleason pattern 4 and knowing what the lesion looks like on MRI, it's one of these classic cases where treating the entire prostate when there's no significant disease anywhere else seems to be somewhat excessive. Just notably, on the template biopsy, you can see left mid, halfway down the slide there was 2 millimeters of grade group 2, it should be grade group 1, it was Gleason 6. I mean, that is really clinically insignificant disease and doesn't make any difference to our treatment decision. So in terms of doing the actual case, he obviously went on to have focal brachytherapy, even though it was a posterior lesion, and it was obviously pretty close to that right neurovascular bundle. And so this, in this particular case, there were 45 iodine-125 seeds administered via 11 needles. And if you look at that photo on the right-hand side there, you can just see the needles going into the template grid, and there's obviously a lot less needles than you would otherwise use for a whole gland brachy. 145 gray are administered to the focal planned, should be targeted volume actually, and the tumor volume actually expands out to 7 millimeters beyond the actual targeted volume initially, and that's obviously because we need to take into account the fact that MRI always undercalls the volume of the actual cancer. So obviously we don't want to leave any cancer cells untreated at the periphery of the lesion. Now, this was a posterior lesion. So we always, for the posterior ones, we always use 15 mils or thereabouts of hydrogel called Spacer to separate the prostate away from the rectum, minimizing and often nullifying any sort of radiation dose to the anterior rectal wall. Follow-up is crucial. Obviously, because it's a novel, focal therapy itself being novel, we need to collect the data and do it really rigorously. So we do that as part of the Liberate registry with serial PSAs every 3 months. And remember, this guy started off with a PSA of 6.7. It dropped way down to 1.4, 1.3, and then eventually 0.8. In terms of functionally, he certainly did have some initial post-treatment lower urinary tract symptoms, only grade 2. And these settled with time. But interestingly, this particular patient had no erectile dysfunction. We do obviously see some erectile dysfunction depending on the location of treatment in other patients. But this guy didn't have any, despite the location of his tumour, and had no bowel symptoms throughout. And that is very typical of what we're seeing in other patients. Now, importantly, again, and this goes along with the guidelines as well in this field, we do a post-treatment MRI and exactly the same type of biopsy, target and transperineal, and obviously targeting the same area. We do that at 18 months. We started doing it at 12 months, but because it's radiotherapy, we were finding that it was too difficult to interpret the biopsy results because of the ongoing radiation effect. So we pushed it out to 18 months. So the top row of images is what you saw before. That's that pre-treatment MRI with the lesion right posterior peripheral zone. And probably if you look at the bottom middle ADC map, what you can see instead of the tumour is a whole bunch of hypointensity, which actually represent all of the brachytherapy seeds. So the actual tumour has really been replaced and scarred, and what you can see instead of the seeds going from PIRADS 4 to PIRADS 2. So MRI becoming negative. Even though we get a negative MRI, we always do a biopsy as well. And this is the post-treatment biopsy at 18 months result. As you can see, it's basically the target and all of the right posterior side has become negative. And on the left-hand side, again, incidental finding of 1 millimeter of Gleason 6 or grade group 1. So that's really, I guess, a very rapid summary of a typical focal brachytherapy case that we're doing as part of the Liberate registry here in Melbourne. Happy to take any questions now or later.
Thanks, Jeremy. That was a beautiful case. Any questions or comments from the rest of the faculty?
Yeah, the first comment I'd just like to make is that I view the 3 plus 5% pattern 4 as a special group. And there's a number of papers. The one I'm most familiar with is from NYU, that the pathology, sorry, I'll just try and get my video back up there.
Hey, Laurie,
Yeah.
When you say, sorry to interrupt you, but when you say 3 plus 5, you might have mistaken. This guy had 3 plus 4.
No, sorry, I misspoke. 3 plus 4 with 5% pattern 4.
Yeah. Go. You go.
That's I'm trying to juggle my my link here at the same time. I see my video is off anyway. So there's a number of papers showing that if you do radical prostatectomy on patients with Gleason 3 plus 5% or less pattern 4, the distribution of the RP pathology is exactly the same as if it was 3 plus 3. In other words, it's an artifact of tangential cut of a Gleason 3 acinus. It's pure artifact in most cases. Mm-hmm. And so I think treatment of these patients is probably unnecessary in most cases. Now, the fact that he's got a PIRADS 4 lesion on MRI might drive treatment to some degree, but I just want to emphasize this point, which I don't think is as well known as it should be, that about 70% of Gleason 3 plus 5% or less pattern 4 actually only have 3 plus 3 in their final pathology. And these patients really should be managed in most cases by active surveillance. It's not a criticism of what you've done, because I think the alternative is clearly focal therapy, where kind of less is more, but they are a very special group and should be managed as such. Yeah,
no, I think it's a really worthwhile point, Laurie. I suppose a couple of things you touched on, in particular the MRI positivity, but also the clinical. It was clinically palpable as well, and so when you start to add those things together on top, in a guy who's in his early 60s, who sort of start to wonder, and hence focal therapy, I guess, keeping his sight. I mean, the whole reason we want to avoid, as you know, radical treatment in the first place is to avoid all the side effects that come with it. So, I mean, this guy, we've managed to treat him and really get away with absolutely minimal symptoms. What we're finding with focal brachy is, because it's exactly the same administration basically as the biopsy itself, that's how patients are experiencing it. It's almost like they're just going in for another biopsy. So side effects really have been, and we have got a retrospective paper out on it that was just published in November last year, just on our pilot study, which was the impetus for going forward and doing the prospective Liberate registry. But the last thing we want to do is over-treat these patients. This is not, focal therapy should, in my view, should never be a replacement for active surveillance. It really should be the next step along that middle path between active surveillance and radical treatment for patients with more significant disease.
Yeah. May I comment? A comment and a question. So a comment on this very interesting topic of 3 plus 4s. Maybe one of the solutions is to treat them on progression that you can observe on the MRI. Then actually, whatever is, I would say, the underlying pathology, pending they don't have a grade, you know that something is happening. He says that was a comment on that. It's a very difficult question for patients as well to answer. Like, do you want to be treated or take a small risk? So that's a nice case. And I have a technical question about, do you think you can deliver focal brachy at the very apex, where actually most of the energy struggles, actually, whatever you take, nearly?
Yeah, I think that's a fantastic question, Clement. So the answer is, I guess, that we have given focal brachytherapy for apical lesions, but at the same time, we do it very cautiously and warily for that exact reason. When the prostate is narrowing down rapidly, getting the right dose within the prostate and minimizing it outside the prostate with obviously, nerves, sphincter, urethra, all just sitting right there at the apex, you've got to be super careful. So it's not ideal. And certainly I have turned patients away who have got an apical tumor. I just have decided it's really not appropriate. But if you go further up the prostate, it's a non-issue. And of course, the absolute best, of course, are the anterior lesions, easy access transperineally. And those patients we're finding just literally near zero side effects because you're away from all the important structures.
Art, you have some experience with the issue of with gold nanoparticles. So I just wonder, is there any difference? I mean, just to quickly poll the panel, you guys do HIFU cryo. We have TULSA here and gold nanoparticles. I just did a guy with an anterior apical tumor today. I did cryo for him because that's what I have in my toolkit now. But I'd love to know what else is going to work well in this arena. Art, you want to comment?
I really think what works best is what you're most comfortable with. Let's start with that, because if you don't understand your energy and how you're depositing, you're going to fail. And I counsel people, I use cryo, nano's a little different, but understand that at the apex, the nerves travel up the front towards the penis. And I think people forget when you're doing a transperineal procedure that there's nerves that are coming at the apex heading anterior, not staying posterior, like when we think of the radical prostatectomy dissection. And I think that's an important thing, especially at the apex, to take that into consideration. I even do hydrodissection at the anterior part of the apex to push the prostate back to work in that space to maybe get some more nerves away, just as an extra safety measure. The nanoparticle trial is closed currently. We're just finalizing our 100-patient data by November. But the idea was it's more of a tumor-specific ablation. Sometimes I really miss it because I think it was focal, but if you plan incorrectly, if you undertreat, there's where your challenges are. And today's case, I pulled a case that was a failure and talked about what do you do and how do you stage for my discussion. So that's where I'm leaving that, and I'll get to my talk when we do that.
That's great. And Dr. Klotz, very quickly, what about TULSA? Do you have any challenges in the anterior apex?
So the way I see it is apical lesions are a challenge no matter what modality you use. In the patient who has an intact bladder neck, my view is that continence should not be that much of an issue insofar as there's some redundancy of continence mechanisms in the normal male. And so we don't hesitate to treat apical lesions with TULSA. In the non-apical patients, we leave 2 or 3 millimeters at the apex. If the patients are having so-called whole gland treatment, I call it kind of subtotal treatment. But our experience to date is that in the limited number of patients who've had apical treatment with TULSA, continence has not been an issue, and it's very feasible.
Right, thanks a lot. So I think in the interest of time, let's move on to our next presentation. We're going to have lots of material for discussion, so please continue to jump in. I think the next case is by Dr. Klotz. Dr. Klotz, please carry it away.
Thank you. Thank you. If we can have the next slide. This is a healthy 75-year-old male who's got no significant comorbidity and no family history of prostate cancer. And back in 2015, he had mild elevation of PSA to 7.2. He had an ultrasound at the time, conventional ultrasound, showing a 12 by 14 millimeter nodule at the right lateral base. Biopsy was Gleason 4+3 in that site only. And he went on to get radiation treatment, HDR monotherapy. This was a clinical trial of hypofractionation at the time, 2 fractions of 13.5 gray with neoadjuvant therapy. And he had a good PSA response, but subsequently a PSA rise. You'll see where I'm going with this case. It's not your typical case of primary salvage therapy, of primary treatment, but rather it's a salvage case. So he had a PSA rise, and 3 or 4 years later, PSA now 5.2, conventional staging negative. PSMA had recently become available, and both PSMA and MRI showed a recurrence confined to the right side, which was where he had original disease, and this was confirmed on biopsy, again showing 4+3 biopsies of the remainder of the prostate were negative. If we can go to the next slide. And so here you see the imaging, the PSMA showing really a very striking area of high intensity in the right lobe, left lobe completely negative in the scan on the left, and the MRI showing essentially the same lesion in the right peripheral zone on the right side. Next slide. So he went on to get focal HIFU, right-sided hemiablation, and with some confidence that, based on PSMA and MRI imaging, this was all the disease he had. Initially a good PSA response, subsequent rise, PSA up to 8.4. Repeat imaging now shows a recurrence on the left side. The right side that had been treated previously was negative, and now the biopsy shows Gleason 3+4 on the left. Next slide. So in here you see the imaging, and it's really fairly striking how the PSMA has shifted from the right to the left, and MRI shows a hypodense lesion on T2 and a restricted diffusion on the left side, not present 2 years ago. So next slide. I assume, Jack, you wouldn't want normal run-of-the-mill garden variety cases for this type of webinar. So, so I think in a case like this, there are kind of limited options for local control. He's had 2 sets of therapy. And so we went on to do salvage TULSA for this case, focal TULSA in a sense, really treating just the left side. And go on to the next. So you can see there the treatment planning, mainly on the left, a little bit on the right, and go on to the next slide. So this should be a movie. If you can hit the next slide again, it should activate. And this just shows dramatically speeded up what this looks like. So you can see mainly the treatment on the left. The boundary. So I don't know, probably most people who have an interest in focal therapy have at least heard about TULSA, MRI-guided transurethral thermal ablation. It's kind of arguably the next generation of HIFU, and the appeal of this technology. That's fine. We can go to the next slide. Sorry, before you do, the bottom shows the post-treatment gadolinium with essentially complete ablation of the treatment zone. Next slide. So the point of this is the appeal of TULSA is that we can go to the next slide. Yeah, so the appeal of TULSA in a case like this is 2 things, I would say. First of all, that the thermometry, which drives the amount of energy that's delivered, gives you very accurate information as to the tissue effect that's been achieved. And this is really the unique thing about the technology. There's no guesswork as to have you really delivered enough energy. And part of that, particularly in the salvage setting, is that you don't have to over-deliver energy. You just deliver enough energy to heat the tissue to 57 or 58 degrees centigrade. 10 seconds at that temperature is 100% lethal to epithelial cells. So it's quite appealing conceptually. And in the salvage setting, the appeal is that the energy is not transrectal, unlike HIFU, which I also am an advocate but I think in the salvage setting, it's very appealing to have a technology that really doesn't drive any energy through the rectum at all, and therefore, at least theoretically, should be extremely safe. And there are now been about 1,700 patients worldwide treated with TULSA. There's not a single case yet of a prostatorectal fistula. So I think the sweet spot for this technology is really in the salvage setting, where I think it has at least some conceptual advantages over the transrectal energy-based technologies, and again, lends itself very much to focal therapy.
Thanks so much, Dr. Klotz. That's a really nice case, and this is really cutting-edge focal therapy. My hospital recently looked at acquiring a TULSA Pro unit, and it's very expensive. So there's a high capital expenditure in obtaining it, and you need MRI time as well. But certainly, it looks like the cutting edge, truly incisionless, transurethral, no needles, don't touch the rectum. Yeah.
Let me just respond to that. That definitely the Achilles heel of this technology is the complexity. So it does require quite a lot of MRI expertise, and it requires a fair bit of time to get the positioning exactly right. So it is never going to be a cheap technology. And I think, the question is there only going to be one winner in this competition for which is the best focal therapy? And I think this will remain a kind of a limousine quality form of focal therapy. And I think there'll be kind of Volkswagen level types of focal therapy as well. You kind of pick your poison.
I don't know if Dr. Klotz picked the best car right now to have a limousine, but everyone has their own choice. We've looked at this as well. They have different business models in the U.S., Jack. So for us, it's a no-cost placement, and the finances sometimes are challenging. But my department of radiology has no interest in doing this. So they're like, if you like to have it, you do so many MRIs on the outside, we can work something out that if you wanted time. So it's a give and take in the situation. If you have capacity, we have an MRI magnet for treatments here at Northwell. So that's kind of the direction, what's available to different platforms. So as we go through this, everyone should always remember, you do what you're comfortable with, and we have not determined any limousines versus Volkswagens yet. Depends what the urologist drives after he does the case.
It has to be electric those days.
Okay, great. I thought that was really good. I think, Dr. Klotz, I think you did prepare some discussion points, so I will visit them since we have a little bit of time. Just coming back to the MR, this is such a beautiful telling picture of where the cancer is, and really tells us about the role of MR in localizing these cancers. So do we still need to do a biopsy in this case? Perhaps I'll ask Art. He's the most.
No. Ask Dr. Klotz. I want to hear what Dr. Klotz has to say.
Well, yeah. So I would say this is evolving. I mean, in the paradigmatic case where you have PSMA and MRI both point to a local recurrence in the same site, how much value is there to the biopsy? Now, I admit I'm kind of old school in this area. I still would like to confirm a positive biopsy, particularly if you're undertaking a therapy that really puts the patient at risk in terms of morbidity. I suppose if you have a very innocuous therapy, the downside risk of overtreatment, if you have false positive lesion, is less. But I still rely on biopsy before proceeding with particularly a salvage therapy, because we know these patients are at risk for complications. But I think it's changing. So maybe a different story in a year or two. I think probably we need more data that, for example, if we knew that the combination of PSMA and MRI being positive for local recurrence was associated with virtually 100% chance of significant cancer in that site, then it's an easier argument. But we don't have that data yet that I'm aware of.
I just like to point out that the bar for prostate cancer we've created for ourselves is so much higher than kidney cancer that has, how many partial nephrectomies do you do with a biopsy proven disease? We don't, for the most part. We just operate. Maybe because there's 2 kidneys, I don't know. And Clement's here. So that in Europe, you hear Emerton talking, why are we even doing biopsies? It's a radiologic diagnosis. And that's what Dr. Klotz alluded to. And for me, I think I'm in the radiologic diagnosis camp. Hopefully in the future, that's where we land this. And we all, I think, agree as imaging improves. And I'm glad everyone shows their pictures because that's important. But my question is for Dr. Klotz and Jeremy, because the 2 of them are probably using more PET CT than us in the US. I order a ton of it now. But the challenge is how do you interpret those findings in patients if, we don't have really what the outcomes are in selecting patients? So if there's concordance, great. If it's PET positive and the MRI lesion's positive, great. What if the PET is negative? Should we be treating? Does it impact your decision making? Because PET does have a false negative rate with the Gleason 3+4 part, and there's a recent paper on that. I just want to know how each of you use PET in your practices. PSMA PET, sorry.
I can respond to that. We're way behind the Australians, I would say, but perhaps ahead of the Americans, which doesn't happen too often in the area of new technology. But we basically have PSMA PET in patients who have recurrent disease. We still can't access it for primary treatment, primary staging prior to treatment. So in this kind of case that I just showed, it's pretty much readily available, and I think it was quite useful. But we just simply can't get it as a primary staging tool. So it's kind of a moot point whether we'd be prepared to abandon the biopsy in patients with suspected prostate cancer who have a positive PSMA for primary local disease.
So not necessarily related to focal art, but we have been very fortunate in Australia with our access to PSMA PET, and we've been using it routinely for a few years now in both the upfront staging situation and also the PSA recurrence post-radical prostatectomy situation as well in particular. So obviously the latter is now sort of part of routine guidelines, and if your PSA is greater than 0.2, a PSMA PET is recommended. So we do that. But yeah, as I say, in the primary staging, basically grade group 3 and above, we've been routinely using it. As the guidelines will say, we still don't know whether it's positive or negative, whether we're making the right clinical decision about therapy after that, because we don't have the trials to support that. But we have found we think it's still incredibly useful. And as of July 1, a bit like the MRI came in terms of reimbursement about 2 years ago, we're actually having all of the staging and restaging PSMA reimbursed by our Medicare system, which is really exciting, because otherwise it's been, well, comparatively it's not too bad. It's about $800 Australian as an outlay. So it's actually not that expensive, but from July 1, patients won't have to pay anything.
Awesome.
Yeah, that's great to hear. Now, it seems pretty niche to do focal therapy as a salvage after radiation failure. So I know some stuff has been published on it. What are your thoughts on focal salvage versus whole gland salvage? Clement, you have quite a lot of experience in ablation with both HIFU and cryo. What are your thoughts on this?
So yeah, we're doing kind of the alternative is hormones. So that's the baseline. I think it's doing a great benefit for a patient who has been well selected. They all have a PSMA PET, MRI, biopsies, and actually we've got very good profile of success in terms of control of the disease. I think what the latest data we have is like at 3 years, 80% don't need any other form of treatment, which is quite good. As Dr. Klotz said, we don't want to harm the patient, so we're really cautious in terms of indications. The rate of fistula with HIFU is higher than in a primary setting. But I think for the patients, it's really a great benefit for them. And very interestingly, even if we're treating some high-grade disease, this is probably the group where the disease is the most aggressive. We still have some good results with ablation. So I think it's really encouraging for ablation as a treatment modality. So, and then side effect wise, they already have been treated with radiotherapy. So erections, I think it's a bit less relevant, but still some of them still have some good response, and the continence rate is a little bit worse, but like still 1 or 2% of urinary incontinence, not less than 1%. But selecting cases, and I think it's for the benefit of patients.
Thanks so much for that comment. Now, let's go on to the third case. The next case is by Dr. Ardeshir Rastinehad.
Thank you. I think there's a niche for focal therapy and salvage because it's less of the side effects, like Clement said. I think radiation is great because the recurrence is easy to see afterwards. We base that on our contrast enhanced MRI portion, and you really have defined borders. It actually is probably the easiest place, I think, to get into focal for visualization of the tumor, because you're not guessing where your margin should be because you have clearly dead tissue and you have residual enhancing abnormal tissue. The question is with this SBRT high dose, sometimes I see normal appearing prostate after radiation therapy, and I wonder what was done. I assume that post-radiation, the prostate should not enhance like a normal gland. And Clement is smirking, it looks like, a little bit on his camera. Maybe he agrees.
I definitely agree with you. Yeah. So yeah, sometimes you can see like what happened there, but and then we can see the lesion beautifully on post-contrast, on post-radiation.
Here's a case of mine today, difficult cases. It's a nano case of mine that I talked about. This technology is a little different than other technologies in the market because we infuse nano shells, a device, the day before it circulates through the bloodstream and it gets preferentially deposited within tumors. And this is a 64-year-old patient. His PSA is 13.8. He had a focal left TZA lesion diagnosed to be grade group 2. All the rest was negative. Good erections, no lower urinary tract symptoms. He was enrolled in our trial. Now, I put up the MRI to show some important things. One, this was just the outline that was made prior to treatment. And I showed the little yellow arrow that this was not appreciated when we were doing it, that there's this dense nodule. It didn't enhance as much, but if you see on the B2000 sequence in the middle, it's really bright. This was included in the ablation zone. I just want you to keep this in the back of your mind because this is going to impact our decisions and what we see in the future case. So he post-ablation, his PSA dropped to 1.2 at 1 month, and it remained stable the whole time. The patient is over 3 years out. You see this post-ablation scan at 48 hours. You can really see that there's complete lack of enhancement. It's homogeneous. It appears that that little nugget that I pointed out that was not originally in the tumor was encompassed and covered by the margin set for the treatment. And this is just a zoomed in version of the ablation zone. I think it's important. We don't do this in normal clinical care, but since this was a study, we're getting this immediate post-op to see before the architecture contracts. I think people are challenged in focal what the biopsy at 6 to 12 months, because all you're left with is with a scar. And I think that's a challenge. I biopsy the scar. It feels like rock hard tissue. When it's soft and pink, you got to think. So, you know, I say all these things because this is what I say in the OR to my residents. So, and, you know, I followed this patient for a while. He was doing great. 1 year, nothing. And then his PSA trend just was very favorable, 1.9 to 1.28, doing well. This is the 1 year, nothing, no enhancement. Notice the B2000 is normal, but I put a little area on a focal area enhancement. It was biopsy. This was negative. Fast forward over, 4 years, you see that you really have this focal enhancement coming back. And he's 4 years out, and his PSA is still low. I don't know how you feel, but again, when I talk about a radiologic diagnosis, I'm not using the PSA. Look at my PSA trend. Who thinks the PSA trend is driving my clinical situation here today? And that's why I feel like I'm leaning towards the Mark Emberton. Basically, Mark Emberton's been a mentor to me since I was a little resident. And he's like, you just have to believe and have science to take you into that direction you want to be and investigate. And I was like, should I invest time in focal therapy? He's like, you should be all in. It's great. You'll be fine. Don't worry. Just do the science. So I kind of gotten to that point where he's given plenty of talks on imaging-based diagnosis, and you can clearly see that there's something here that's not right. So I'm not here to brag that I do a great job. I'm here to show you that I'm a concern for my patients, and we do the workup. And unfortunately, that little tiny focal enhancing area was positive for recurrence, 4+3, 90% pattern 4. That would be great. If that was the only spot, I would consider maybe salvage. I brought this case up for a discussion. Unfortunately, if you look in the lower left on the 3D diagram, there's a 4+3 now posteriorly. And, that I did not see clearly on the imaging. The T2 is still normal in appearance. There's a little bit of an abnormal enhancement, but it was nothing clear. So I don't know if post-ablation altered how things appeared, but this is the core. Or, of course, we all know sometimes the cups get messed up, but I have to take the pathology that comes. And in this left posterior base is now 4+3, and we have 4+3 in the target. And what would you guys consider? For us, the patient, this is a brand new case. The patient's still in the diagnostic workup. And I wanted to present this today as a discussion of how the group felt. I have not made a decision on this patient, but these are the things that we're challenged with. So I thought this would be a decent launching point for discussion.
Can I jump in? So, yeah, very, very, very interesting case. I don't have any experience with the nanoparticles, but it looks. I think the lesion next to the ureter are always challenging with interstitial treatment. I think in this case, so just to summarize, it's got like recurrent disease anteriorly 4+3, and then posteriorly on the base 4+3 as well.
Yeah,
so probably
that was not visualized, not showing up on the MRI. I did not appreciate it, but there's post-focal changes post-ablation, which leads to some limitations, right?
So the first thing we would do would be to complete the staging with PSMA PET. So primary pattern 4, and then it's recurrence. This is what we would do. And then if it's negative for spread, I would probably measure, if we can reach the entire bit with HIFU. If it's not too far away from the rectal wall, I would have a trend to propose them a left hemi ablation. And probably you will have to encompass the urethra to take a margin to it and put an SPC to make sure it doesn't get like a stricture. So this is what I would propose, and obviously you can go for radical treatment, but you might want to stay with a focal therapy approach.
Jeremy, please.
Art, can I ask, so with your experience with nanoparticles, have you had to do any salvage radical prostatectomies, and if so, what's it like?
So I didn't do it personally, but my partner at the time was a chair at Sinai. And he said he'd even noticed that it wasn't the fibrotic reaction you see from HIFU or cryo. He was like, I would tell you it would have been a normal prostate for me. I think a lot of the challenges in the beginning with focal therapy is adequately drawing the tumor and then adequately planting the margin. The UCLA data says you have to have an extra centimeter, I think is overkill. I think the quality of your imaging directly impacts the need for how big your margin is. And then placement of the energy is the next impact on how big of a margin you need.
Right. So that original focal therapy was all anterior.
Yeah.
And it sounds as if, the radical experience or, post-focal, post-nanoparticle is favorable. So I suppose I would sort of lean a little bit more conservatively towards going ahead then with radical prostatectomy and as the salvage for this guy. He's got a couple of quite disparate lesions now. He's got recurrence within the infield zone, and then a new tumor or possibly unnoticed previously in two very different parts of the prostate. Now, of course, you could maybe retreat the left-hand side, but I think at least, and again, maybe this is my Australian perspective, but I think because focal is still, we're still developing all our evidence base and so forth, that when it fails, especially if there's more than one lesion and they're at different parts of the prostate, I'd lean towards radical prostatectomy if the experience is that it's feasible and safe to do so?
Well, I kind of agree with Jeremy. I think one of the problems with predominant pattern 4, you don't have nearly as much wiggle room in terms of being confident that the patient is not going to metastasize while you're trying to eradicate the local disease once they've failed the first time. So, and the second important thing about this case is he has one lesion that was not visible on MRI. He may have others that you don't know about on the contralateral side. So, and he's 90% pattern 4. So this patient, it's time to pull the trigger, radical treatment. I personally favor radiation as salvage therapy post focal therapy because of the data that comes from a few centers that with radical prostatectomy, at least post HIFU and cryo, there's an increased rate of positive margins and PSA failure. I have personal experience with these cases that you can get a lot of fibrosis, ablation of the plane between the prostate and Denon-Villiers. It can be quite a tough dissection, depending, of course, on where the energy was delivered. But with radiation, I believe that the increased rate of complications post-focal therapy is really minuscule, and therefore I kind of, unless they're quite young, I drive them towards radiation as the salvage therapy for the failed focal therapy patients. And this patient for sure, like, don't horse around. You may. That's
how I lean typically too, but his insurance would not cover a PSMA PET CT, so he had conventional staging, which was all negative, and multiple letters. They wouldn't give it to me because they just didn't feel like this was recurrence, first of all, because of focal, that was a challenge. And then his type of insurance that he had is just obstinate to any advanced imaging in general.
So we had a couple of comments from the audience. Let me just share them here. From Tara Morgan, do you ever send these patients for SBRT or IMRT at this point and abandon the focal approach? So I think Dr. Klotz has already responded to that. I think many of us would consider seriously radical treatment at this point, rather than a repeat focal, though that potentially could be done if the patient insisted, with caveats. And another question for Dr. Klotz is whether you need a 3 Tesla MRI for TULSA and whether TULSA can be done under local anesthesia. Dr. Klotz, I'm not sure if you're
no, sorry.
Yeah.
So yes, I mean, of course, it's done by MRI. So they're having an MRI during the procedure, but our practice is to do MRI prior to the as planning in all cases.
I think what they meant was whether you could do it with 1.5 Tesla, perhaps. Would you need a 3 Tesla magnet?
So what you need is the thermometry capability, and 1.5 Tesla machines do have that capability. So obviously it's the signal to noise ratio is better with 3 Tesla, but yes, you can do it with 1.5. I saw a new device, a 0.6 Tesla mobile MRI at the AUA, seen before. I am not sure whether that has the thermometry capability, but in theory, it's possible without the very high resolution of 3 Tesla.
And could it be done under local anesthesia? In your
you need immobility. That is we did the cases under spinal initially, and in the pivotal registration trial, and it doesn't work as well because even the slightest motion, then you've got to re-MRI the patient, recalibrate motion. Patient motion is a real deal breaker in terms of prolonging the procedure time. So I would say at this point, the answer is no.
Thanks, Dr. Klotz. Let's go on to that last case. This is a case provided by Clement, and it will be presented by his fellow Dr. David Maffei. David, please.
So thank you, everyone, for the invitation to speak today, and thank you to Mr. Orczyk for presenting a case on his behalf. So today I'm going to present a case, a second chance of focal treatment, redo cryotherapy after primary HIFU. I know I'm conscious about time, so I'll try to keep to the facts. We have his external referral of a 68-year-old man who was initially had some external diagnostic workup with PSA06, an external MRI showing a lichenified lesion in the right PZ, an external trust biopsy showing lesion 3+4 on the right side only. This was a repeat MRI scan that we did when we saw him to have high quality imaging, as that is essential for our investigation. And you can clearly see the lesion on the right side here. So in order to evaluate him for eligibility for focal therapy, we put it through our focal multidisciplinary team meeting with in the presence of our radiologist and pathologist, where we reviewed the MRI and we reached a consensus between the concordance of the pathology and the MRI. We also looked at the localization of the disease and confirmed that the anteriormost part of the disease was at 36 millimeters between the from the rectum, and therefore confirmed the suitability for a focal HIFU. We confirmed that we would be able to reach a complete ablation of the target with a margin and respecting the anatomy as well. So here you can see the images from the HIFU treatment with the anteriormost treatment zone reaching very well the anterior part, and also good HIFU Uchida changes on ultrasound. The initial follow-up was good with complete continence and maintained erectile function using some PDE5 inhibitors, and we reached a very good drop in PSA from 70%. But after 1 year, we saw that the PSA rose higher than we would expect, and we repeat an MRI scan, as you can see. And we did a targeted biopsy of this lesion on the right side, the part of the previous ablation. Unfortunately, the biopsy came back as negative, which was surprising given the likelihood, but there was only a partial amount of tissue analyzed in the lab. So what we decided to do, because we believed in the positivity of the lesion on radiology, going back to what we discussed before, we repeated an early MRI scan and repeated a target biopsy, which did confirm lesion 4+3, not 5 millimeters in the right side. And there was only 1 millimeter of lesion 3+3 in the left posterior side. Therefore, we discussed this in our focal MDT, and we were discussing potential options for the patient, going between prostatectomy and radiotherapy, or we discussed whether it would be possible to offer him a redo right focal therapy and maintaining the left side on active surveillance given the low grade and low volume. So the rationale in this case for repeating focal treatment was that we had the initial treatment was really good at the posterior part, and the residual disease was anteriormost margin, where there's little overlap in the treatment. The focal therapy would have been ipsilateral, therefore having low damage to the contralateral side and therefore maintaining good functional outcomes. And based on the MRI and the anterior location of the lesion, we decided for an interstitial treatment for easy access to anterior portion of the gland with cryotherapy. So this was all discussed with the patient, who preferred redo focal therapy in view of minimizing the side effects. Here you can see again the pre-HIFU images and the MRI that was done pre-HIFU. So the location, the lesion was very well located anteriorly at the anterior margin of the previous ablation zone. In May 2019, we performed a redo cryoablation, and you can see on the right side the treatment plan with the position of the the 2 cryo needles and the thermoprobes as well. We had 2 cycles of freezing and thawing with excellent coverage with the ice ball and no intraoperative complications. Again, this you can see the early post-cryo scan that we do regularly, routinely at 2 weeks after the cryotherapy treatment. And you can also see the isotherms where we reach -40 degrees at the location of the tumor and 0 degrees at the more extensive treatment. There was good coverage of the lesion and no complications. The follow-up is PSA and MRI driven. We are 5 years down the line from the initial HIFU, and the PSA has been very well stable. The 1 year post-op MRI showed good treatment and lesion coverage with no new lesion and no recurrence. We're currently awaiting for the 3-year post-cryo MRI, which is planned in July. And the functional outcome so far has been very good with complete continence, still good erectional function using PDE5 inhibitors, and no complication afterwards. This is, as you can see, we can see really well the 1 year post-op MRI scan after the cryo, where there is no evidence of residual tumor.
That's great. Thanks so much, David. Yeah, great presentation.
Welcome.
Yeah, I'd like to invite any comments from the faculty. What do you guys think?
It's a fantastic case. It raises the question about sequencing, basically. And if you have a failure with one modality, is there an advantage to switching to a different form of energy? And I have absolutely no idea, and I don't think we have any data on this. It's a very interesting and unexplored question.
So I'm going to jump in. So yes, the case was to show really that the choice of energy has to be based on the location where you are. Then you can change one or the other. But I may leave other comment before I say more actually.
Yeah. Well, I noticed your beautiful MRI pictures, and I noticed that you seem to have a schedule where you will do the MRI 1 year post-treatment. And if I'm not wrong, your protocol seems to be that if you don't see a target, maybe you'll do an MRI again 3 years later. So am I right to say that? Is that how you do it?
Yeah, exactly. So we've got a schedule for, depending on the risk of the disease, that so we do early MRI post-op because I think it doesn't say if you eradicated everything, but it will indicate for the follow-up what has been ablated and the quality of the ablation. So one at 1 year, 3 years, 5 years. And then we are very much guided by the MRI, but the PSA as well. So if there is any discrepancy between the PSA, which is rising, and we don't really understand why, we still trigger a biopsy. If the MRI is positive, but the PSA is still stable, we trigger even more a biopsy. So it's a very much image-driven protocol we have. And in terms of data about that, I think we've got long-term data now showing, we don't have patient metastasizing. So I think this is really reassuring. And in terms of data, I think we've got 20, 25 cases like cryo post HIFU, and I think changing modalities. And we learned from these cases as well that probably the entire component was too much on this case for HIFU. And another comment I wanted to do about HIFU, the HIFU technology, is really about what we do now is a dose escalation. Is like we do overlay multiple times the treatment on one zone to make sure that we have enough energy going there. So in this case, probably only one layer on the core of the lesion was not enough.
Perfect. And just a question to the other faculty, Art and maybe Jeremy, perhaps you could weigh in on what's your follow-up protocol after focal therapy. I mean, we agreed that we should do biopsies maybe a year later, but how about down the road? What do you tell your patients?
So I'll go first, at least. Clement and the team from UCL, these guys are leading the area in the thought or their mental progression of follow-up. If at 1 year I do a biopsy, because I have a lot of trials, and another plug for the Focal Therapy Society registry, we want to get more people included. We have, I think, up to over 500 cases already put into the registry, and we're looking forward to expand that every day. So please participate. It's agnostic to the modality, but I do a biopsy at 1 year, and then I more or less use an active surveillance protocol looking at, you know, what their initial pathology was, what the PSA trend is, and then I image. As you saw in my case, it was a 4-year post-ablation biopsy, so it's 3 years from his 1 year biopsy. And I used imaging, not as PSA, to drive the conversation. And it's a difficult task because someone's like, what's the, should PSA be a metric of success? I don't think there's any clear cut what each patient produces, because PSA is a function of leakage into the bloodstream, depending on the tumor architecture, can, I think, change a little bit. I just look at it as a leaky silo. How are the glands maintaining the PSA? Post-focal, if you've ablated everything, and you can see my patient went from 13 to 1.2, 1.9, somewhere around there. So that's kind of how we've approached it. So imaging drives more of our intervention, and our imaging occurs at the most, I wait 3 years and re-imaged like an active surveillance PRIUS protocol, which is at 3 to 4 years post-confirmatory biopsy.
Thanks, Art. How about you, Jeremy?
Yeah, similar. So as I mentioned, with regard to focal brachy, we get an MRI and targeted and template transperineal biopsy at 18 months for everybody, regardless of PSA. Even if their MRI has become negative, we'll do the biopsy anyway. After that, the protocol is much less prescriptive. We still do 3 monthly PSAs out to 2 years, and then 6 monthly. But after that, it does depend actually on the PSA to an extent, if presuming that post-treatment biopsy shows no significant cancer at all. And like Art said, you'll often have a tiny amount of low-grade disease elsewhere. So I think we are actively surveying the rest of the prostate, the untreated portion of the prostate. So I think an active surveillance type of follow-up is appropriate.
Thanks. I guess hopefully the evidence from more mature series as well as the focal therapy registry will help to inform us about that. Well, we had a wonderful hour, but I'm always mindful of the time. We are now at the end of our allotted hour. So I just want to thank all of you. We had an excellent discussion covering the points of treating limited volume intermediate grade cancer with focal brachytherapy. We had a case of salvage focal therapy after radiation therapy, and we had some excellent points on when to do repeat focal therapy or fall back on whole gland salvage. So I'd really like to thank the faculty panel for the wonderful discussion and the audience for being here to learn and share these lessons with us. Now, this is the third webinar in our series, and this, together with our first 2 webinars, are available on the Focal Therapy Society website, which is at focaltherapy.org. So please, for those of your friends and colleagues who have missed it, please send them there to...
tumor there somewhere?
We are planning for our next iteration in August 2022, so please look out for our next email and join us again. We're always looking to improve, so also take a moment to fill out the evaluation form before you log out of the Zoom meeting. Again, thank you for your participation, and I wish you a great day or evening ahead. So thank you, everybody.